10:30 for me. Hi, good morning, afternoon, evening, everyone. Thank you for being here today. This session is on supporting blood and milk donations through research. And this session is hosted by Australian Red Cross Lifeblood, also known as Lifeblood. So just a few reminders. Please rename yourself if you can with your full name and organization. Mute your microphone and keep your video on if you can't because of low connectivity, obviously switch off. If you have any questions to the speaker, can you please hold them to the end of the session and use the chat function, or you can raise your hand and our moderator will ask you to unmute. Also, if you have any IT questions, please put them in the chat and an administrator will help you. Finally, sessions are recorded. Participants commit to not taking pictures off screen or of other participants without permission. Thank you. If you want to turn on your AI generated captions and translation, you've got a function at the bottom right of your screen using with more captions, translation, and then you can select your speaking language and the language in which you want to see your caption. You will have more details in the chat. Now, we would like to acknowledge and pay our respects to the past, present, and future traditional custodians and elders of this land and the continuation of cultural, spiritual, and educational practices of Aboriginal and Torres Strait Islander peoples. So this session has three speakers. We start with Amanda Thijsen, who is a senior research officer who has just ended a PhD thesis. Her thesis is on, really looking at how research evidence is translated into clinical practice. So Amanda works on ways to improve the safety and experience of blood donation. She's interested in combining insights from data, interviews, surveys, and clinical trials to improve our management of adverse events, such as fainting. The second speaker, myself, research fellow specialized in tropical infectious diseases with a focus on vector-borne infections and climate change. I work on transmissible infections, or known as TTIs, and explore more broadly how emerging risk could be driven by environmental shifts. I have a PhD in medical and veterinary entomology and epidemiology. And finally, our last speaker is Leonie Walter, a postdoctoral research fellow with knowledge about the milk donations we receive, with goals to make processing improvements and give clinicians as much information as possible about the composition of our donated breast milk. That includes looking at how the nutrients vary in batches of pasteurized donor human milk from different donors. Leonie has a PhD in lactation physiology from the University of Melbourne. So we just wanted to explain how Lifeblood is working, what is about Lifeblood. So formally, our purpose is to provide life-giving donations for life-changing outcomes. And we are an arm of the Australian Red Cross. And we are funded by the Australian federal, state, and territory government. We are Australia's only blood and plasma collector, a national organization covering a large geographic area, as you can see on this figure bottom left. And we have about 103 blood collection centers plus mobile units to collect blood around Australia. And to give you a sense of the scale of what we are doing, here's a quick summary of what we achieved last financial year. So we delivered about 1.1 million of fresh blood products to hospitals and healthcare providers to help Australian patients. We also supplied 869 tons of plasma for fractionation to CSL Behring. And in our new business space, we supplied over 4,000 liters of human milk for very premature babies. And I need to mention the research team, which is why we're here today. So we have around 60 researchers that are located in Melbourne, Sydney, and Brisbane in those different fields that you see. And we are going to hear a bit more about Amanda just now. Thank you.
Thanks, Elvina. Hi, everyone. So my name is Amanda Thijsen, and I'm here to talk about our research to support the iron health of blood donors. Next slide, please. So to start off, I'd like to give you a bit of background about donating blood at Lifeblood. As a donor, you can give 3 types of donation types. So the most well-known donation type is blood. That is blood that's taken straight from a donor, and after it's donated, it gets separated into red cells, plasma, and platelets in our labs. People give about 470 mils of blood, and that's roughly 8% of the average adult's blood volume. And this donation takes about 10 minutes, and people can donate every 12 weeks, so roughly about every 3 months. The other 2 are specific blood components. One is plasma and one is platelets, and they both use a process called apheresis to separate either plasma or platelets and return your red cells. These donations take a little bit longer, about 45 minutes to an hour, but you can donate more frequently, once every 2 weeks. Next slide, please. So I'm curious about our audience here today and who has ever donated blood or blood products, such as plasma or platelets. Are you able to message in the chat a yes or a no if you've ever donated blood? Thanks, Pat. Oh, I see lots of yeses. This is great. I'll just keep going. So why are we interested in iron? So when you donate blood, that is blood that's taken straight from a donor, you donate your red cells, which contain hemoglobin. And this obviously causes a drop in your hemoglobin. After you donate, your body uses its iron stores to replenish your hemoglobin and red cells. Your body will be more efficient at replacing these if you have healthy iron stores. And it's important to maintain healthy iron stores, as low iron can lead to fatigue. Low iron may also lead to low hemoglobin or anemia, and this may cause breathlessness and dizziness. Next slide, please. At Lifeblood, we perform routine checks to make sure that a person is healthy and well to donate on the day. So once a person has signed in at the front desk for their donation appointment, a donor is then asked to complete a donor questionnaire and is then taken to an interview room to discuss their answers, but also to check their hemoglobin level using a finger prick test. So in the little box here, hemoglobin is a protein that carries oxygen from the lungs to the rest of the body, and it is tested before each donation to make sure it's at a safe level to donate. Your body uses iron to make hemoglobin. So when your iron levels are low, the body can't produce enough hemoglobin, leading to iron deficiency anemia. So hemoglobin and iron are linked, but hemoglobin tests can't tell us what your iron levels are. Next. Yeah. So to supplement the hemoglobin test, Lifeblood started the phased introduction of routine ferritin testing in August 2023. Ferritin is the protein in your body that stores iron. So we started with phase 1, where all new female blood donors have their ferritin levels tested at their first ever blood donation. 3 months later, we introduced, expanded this to include new male donors in November 2023. And the last phase was implemented only just last November, where now every donor will have their ferritin levels tested at every 10th donation. Next slide. So what does this mean for the donor? Once they've passed all their other checks and tests, a blood sample is taken during a blood donation, and we test their ferritin levels afterwards in our labs. Donors with a normal test can see their ferritin level in the Lifeblood mobile app or our online web portal within 2 weeks. For donors with an abnormal result, they are sent a letter informing them of their ferritin results, and for those with a low ferritin result, they are recommended to visit their doctor, and they are deferred from donating blood for 6 months. But they can still donate plasma, as we do not take their red cells during a plasma donation. For donors with a high result, so up to 1,000 micrograms per litre, they are also sent a letter recommending they see their doctor for further investigations, but they can still continue donating blood. For donors with a very high result, so more than 1,000, they are permanently deferred from donating blood until they've been cleared by their doctor. Next slide. So as you can see, there's a potentially big impact on a person's ability to donate with this new test. Our research focuses on evaluating the impact of this change on the donor experience and the blood donor behaviour. So specifically, we're using routinely collected donation data to look at the prevalence of iron deficiency and elevated iron. We're also looking at how ferritin testing affects blood donor return behaviour. We're also sending out surveys to our donors who have recently had their ferritin levels tested to see how it has affected their donation experience and their intentions to continue donating blood. We also want to learn more about their knowledge of iron health and what we can do to improve how we communicate to donors about ferritin. So I'd now like to present some of our donation data insights here. Next slide. So one of our main objectives is to look at the prevalence of iron deficiency and elevated ferritin. But before I show the results, I kind of want to see which group do you think has the highest proportion of donors with acceptable iron levels. So if you can put in the chat whether you think it's A, new male donors, B, new female donors, C, returned male donors, or D, returned female donors. And I've got the chat on my other screen, so I'll be sort of looking at this side to see what people think has the highest proportion of donors with acceptable iron levels. Quite a bit of a spread happening here, some A's, some B's, some D's. And I'll let you know that, next slide, Elvina. So we can see here that our answer is B. If you go one more, next slide. Yep, I've got my circle there to highlight. It's the new female donors. So looking at low ferritin, we can see that the highest proportions are in our return donors, in particular male return donors. In our new donors, we see that only 4% of females and 2% of males have low ferritin at their first donation. But if we look at high ferritin, we can see that new male donors in particular have the highest proportion of high ferritin with 7%, while the other groups are only sitting at 1%. So you can see that new females have the biggest proportion of donors with acceptable ferritin levels. Next slide, please. We also looked at how many donors have returned within 9 months after their first blood donation and compared return rates between the ferritin groups. As you can see, the return rates on this graph here with women in blue and men in black. As you can see clearly, you can see the lowest return rate in the group of donors with a low ferritin result. Elvina, if you hit one more next. Sorry, I've got, yeah, there we go. So to get a bit more of an understanding of this effect, we ran a logistic regression model and found that the likelihood of a female donor returning was reduced by 65% if they had a low ferritin result compared to if they had a normal ferritin result. And similarly, we found a 57% reduction in the likelihood of a male donor returning after a low ferritin result. So we can clearly see there's a negative impact here of a low ferritin result on donor return. Next slide, please. So to get more of an understanding of how the ferritin result may have affected the donation experience, we're also conducting surveys. So for each implementation phase, we've been sending donors an invitation to complete an online survey 6 weeks after their donation to assess their donation experience, their knowledge of iron health, how they think their ferritin results affects their eligibility to donate, and their thoughts on how we communicate about ferritin and iron. We're also sending donors a survey 6 months later to understand long-term health behaviours, such as visits to their doctor, taking iron supplements to manage low ferritin, or whether they've started donating therapeutically to manage high ferritin. We finished our survey work with the first 2 phases, that's new female and male donors, and we're currently still surveying return donors. Today, I'll show you some of our survey results from our new male donor survey. So one of our main aims of the survey is to look at satisfaction with the donation experience and iron information provided. As you can see here that our surveyed population, they were very satisfied with both across all ferritin groups. Next slide. We also asked them whether they understand their ferritin results and the implications on their eligibility to donate among those with a result outside of the Lifeblood acceptable range. We can see in this graph here that donors with a low result had a very good understanding, but we can also see that we can improve how we communicate with donors with a high and very high result about their donation eligibility. Next slide. We also asked donors about their knowledge. So we asked them about their level of understanding about the difference between ferritin and hemoglobin, their understanding about the reason for the ferritin and hemoglobin test, their understanding of how blood donation affects iron, and their understanding of what actions they should take to manage their ferritin. This last item was only asked to donors with a low or high iron result. As you can see, new male donors had a good understanding of actions and how blood donation affects iron. But they understood less the difference between ferritin and hemoglobin and why Lifeblood tests both. So our next steps are to use these survey insights to update how we communicate to donors. So we'll be updating our results letters as well as how we communicate about the different tests in our in-center conversations. We'll also continue our research by monitoring donor return trends over a longer period of time, as well as the impact on our return donor. And we'll also be looking at our survey results in our return group later in the year. And I'll now hand it back over to my colleague, Elvina, who's been doing amazing with her slides coordination. Thank you.
Right. So thank you so much, Amanda. So we will stay on the topic of blood, but we are also going to look at how we can protect and improve its blood supply to ensure that it's there when people need it most. So let's begin with the core of the topic. When we talk about blood supply, we don't just mean donations. We mean a full chain from collection to testing, processing, inventory management, and delivery to hospitals and health systems. And why is this chain so important? It's because blood saves lives every day. It's used in trauma care, surgery, cancer treatment, childbirth and chronic diseases, complications, and emergencies. And in short, a strong blood supply system is not a luxury, it's a lifeline. And what makes the task a bit more complex is that blood is a fragile resource. Red cells last up to 42 days, platelets only 5-7 days, and plasma can be frozen for up to a year. So these products are highly sensitive to temperature and timing. So any delays and disruptions, especially during natural disasters such as earthquakes, but also floods, cyclones, bushfires, can lead to dangerous shortages or waste. And so we need to ensure timely, safe, and sufficient blood from collection to delivery. Globally, we collect about 118 million blood donations each year. That sounds like a lot, but distribution is alarmingly unequal. 40% of donations come from high-income countries, even though they represent only 16% of the world's population. Donation rates per 1,000 people is about 31 in high-income countries, while it's around 5 in low-income countries. In 2017, 61% of countries couldn't meet blood needs. These disparities matter because the need to supply ratio is highest in many of African nations or Southeast Asia and the Pacific, and the demand keeps growing. So I just invite you to make it a bit more interactive, to go in the chat and click on the link that will appear soon. So it's just to respond to the question where people are most willing to donate blood. So if you have a bit of time, we've got about 15 seconds to click on this doc. It's a Google form, and you've got a list of countries. Just to answer, where do you think people are most willing to donate blood? 5 more seconds. All right. So the answer is from Saudi Arabia, followed by India, China, and South Africa, knowing that it's a study done by Statista, and it's been done in 2018 on only 28 countries. So it has its limit. Now, the safety and availability of blood are deeply influenced by the context and capacity of each blood service. Each country's blood service. So here in Australia, we are very fortunate to have one of the safest blood supply in the world. We've got a lot of different policies in place, testing and management plan. However, even the strongest systems can face vulnerabilities. These can be grouped into several key areas. So first one, biological risks, such as transfusion transmissible infections. So we've got the example of HIV, hepatitis B, C, syphilis, West Nile virus, Zika, dengue. And with climate change, we're seeing new pathogens taking place into new regions. We've got also system gaps, so outdated screening tools, human error in labeling or transfusion, and unregulated or counterfeit products. Donor challenges also, we can have low rates due to fear, misinformation, or cultural beliefs, aging populations, more people needing blood, and fewer eligible donors. And also seasonal shortages. during flood seasons, holidays, pandemic, and finally, environmental threats. So disasters and conflict can disrupt collection, storage, and transport. And climate-related events like floods, bushfires, heat waves could reduce donor turnout and strain logistics. Safe blood isn't just about volume, it's about also process, which efficiency and quality depends on controlled transport and temperature monitoring, secure storage, rigorous donor screening and testing for different infectious diseases that are possibly transfused, advanced screening for things like cytomegalovirus or also human T lymphotropic virus 1, malaria, got also bacterial screening, leukodepletion to reduce immune and infection risks, and also, future-proofing our systems. So ensuring that we've got climate-resilient infrastructure, more mobile blood units in remote areas if possible, and the use of innovations such as drones or even walk-in blood banks in remote areas or emergencies. Evidence saves lives, and this is where research comes in. So research helps us refining the eligibility and deferral criteria, improving TTI screening, enhancing blood component preservation, but also predicting demand more accurately, optimizing resilience of blood supply, informing best practices in transfusion, also planning for rare blood types management, and ensuring equity, especially for marginalized populations. And testing and adopting new technologies such as pathogen inactivation or AI and early warning systems. As discussed earlier, maintaining blood safety is critical, and certain infections can be transmitted through blood or through transfusion. And to stay ahead of these risks, it's really important to have coordinated global efforts, including serosurveillance, so the surveillance of the presence of pathogen into the general population, but also blood donors to track population-level exposure, environmental monitoring to detect shifts in disease patterns, also the integration of public health and climate data to understand broader risk factors, and predictive tools to identify and respond to emerging threats early enough. In 2023, we conducted a systematic review examining the impact of pandemic and natural disasters on the blood supply globally. At the onset of COVID-19, so until June 2022, blood donations declined sharply worldwide. That was driven by fear, lockdown restrictions, and a general lack of preparedness. In contrast, we saw that natural disasters like earthquakes often trigger an immediate surge in donations. This is well known simply because individuals are motivated to help in the aftermath. Our review identifies several effective strategies used during the COVID-19 pandemic to stabilize the supply chain. So that was first, suspension of elective surgeries to reduce demand, public awareness campaigns to reassure and motivate donors, and the designation of blood donation as an essential health service, which exempts for lockdown restrictions. So these measures prove critical in maintaining supply during a period of extreme disruptions and uncertainty. We are seeing exciting and promising advances in how blood safety and supply are managed, partly thanks to research-driven tools. Some examples are, but are not limited to, the use of artificial intelligence and dashboards. AI can help detect risk, forecast demand, and track infections, while mobile tracking and early warning systems can improve coordination and flag potential early enough disruptions in supply chains and transport logistics. While many of these solutions show great promise, not all are fully developed or widely implemented yet. But innovation doesn't happen in isolation. So global collaboration through World Health Organization, the Alliance of Blood Operators, Asia Pacific Blood Network, but also International Federation of Red Crescent, and Red Crescent, the International Society of Blood Transfusion, and national agencies, and more. This global collaboration is really, really essential to share data, also to share preparedness plans and regional simulation exercises, all these help ensure that countries can respond together, faster, and more effectively. While global innovation and collaboration are critical, they must be grounded in strategies that can withstand real-world disruptions, especially those driven by climate change. Climate change is an increasingly disruptive force in blood systems, not just affecting health, environment, economy, but also donation drives, transportation, and cold storage infrastructure. Our recent scoping review was the first to globally assess how climate change could affect every aspect of the blood supply chain. I won't enter into detail, but we've got the figure on the right. Emphasizing the need for further research, but also preparation as demand for blood may also rise with health and disaster trends. So we also outline key adaptive strategies that I put here. So, to create lasting impact, we need systems that are smart, connected, and resilient, and able to adapt, respond, and recover from any challenge. And effective innovation and climate adaptation must be built into resilient systems. So this means integrating climate and health data, reinforcing infrastructure and securing backup systems, but also, regional contingency planning, mobile and solar power units if feasible, but also cross-trained staff and diversifying supply chains. Also, the use of real-time tools and also designing for equity is also important. So regular testing and sustainable practices are key to keeping this system strong. And these measures are really essential to future-proofing blood services worldwide in the face of environmental instability. And I'd like to say that research is the engine behind these advances, really helping to identify challenges and driving solutions that build a stronger, hopefully more resilient future for blood safety. So let's now hear from Leonie and the milk research.
Thank you, Elvina, and hello, everyone. I'll be talking to you about milk donation and a bit of the research we do. At Lifeblood, we have 2 milk banks or processing centres, one in Sydney and one in Brisbane, and we started supplying milk in 2018. We now supply milk to over 35 hospitals across Australia. In that time, we've recruited about 2,100 donors, supplied over 20,000 litres of milk, and we estimate that we fed about 9,000 babies with that milk. Next slide. So who are our recipients? Our recipients are very preterm babies in hospitals. They're usually born less than 32 weeks of gestation and they weigh less than 1,500 grams. It's important to point out here that they only receive donor milk if their mother's own milk is not available to feed them. Next slide. So I want you to have a little think about how big you think the size of a stomach of a preterm baby is. They weigh about between 500 and 1,500 grams. That can even be less than 500 grams. So do you think it's the size of a pea? Then please write the letter A in the chat. If it's the size of a cherry, write the letter B. If it's the size of a walnut, write the letter C. And if you think it's the size of a plum, please write the letter D in the chat. And I'll give you a few seconds here. I'll see what, yeah, let's see some A's, some B's, a couple of C's. Okay, so I've tricked you a little bit here because obviously there's a range of sizes of babies. So 2 of these answers are correct. There's somewhere between the size of a pea and the size of a cherry or marble. So how does milk donation work? There's a lot of similarities to blood donations. First of all, our donors are mothers that have more milk than their own baby needs. So they will get in touch with us. Sometimes they're still in hospital themselves or they're from the community, so they'll register online. Our donor coordinators will then contact them and go through a donor questionnaire, which is very similar to what you see in blood donation. Once they're deemed eligible, the donor coordinators will visit them in their home or in the hospital and they will collect the milk in a frozen state. They will also take a blood test, and that's to screen for infectious diseases. It's then sent to one of our processing centers. I'll just go back one. Thank you. Thanks. It's then sent to the processing centers where it's heat treated, and then it's tested for microbiological safety, and then frozen again, supplied to hospitals and used to feed babies. Next. Thanks, Elvina. So here you can see how processing works. First of all, we pool milk from individual donors, so we don't mix milk from several donors. We pool about 3 to 5 liters from that donor in a jug. It's divided into bottles, and it's then heat treated at 62.5 degrees for 30 minutes. Next slide. So why donor milk? The WHO recommends that where it is not possible for the biological mother to breastfeed, the first alternative, if available, should be the use of human milk from other sources. And there's also some good scientific evidence behind this recommendation. Next slide. So we know that about 13 million babies are born preterm worldwide each year. About 15% or 2 million of those are born extremely or very preterm or low birth weight. Mother's own milk is the best nutrition for these babies, but many don't have access to enough of their mother's own milk. So donor milk, when used instead of infant formula, reduces the risk of necrotizing enterocolitis in very preterm or low birth weight babies by about half. Necrotizing enterocolitis is a severe inflammation of the gut and is one of the main concerns for preterm babies and has a high mortality rate. Some of the challenges with donor milk are that protein content of human milk can be insufficient for adequate growth for these really preterm babies. So fortification is often necessary and is done with a standard amount of supplement. So what that means if you add a standard amount is that the varying protein content in donor milk means that sometimes babies can receive insufficient total protein to support their growth. So donor milk composition, we know, depends on the characteristics of the donor pool, so who are the donors, or different processing methods. There's also some individual donor characteristics that can impact that. So here on that graph, you can see how days in lactation or time postpartum impacts, for example, protein content. So it declines initially and then plateaus. Next slide, please. So here you can see some of our research that we did in 2022. We measured macronutrient content in 200 batches of donor milk. And you can see in the graph here that especially for protein and fat content, there's a high variability. Just quickly, I'm showing 2 protein measures here. So crude protein is what we measure, and then we calculate 80% of that, which we describe as true protein, because that's metabolizable for the baby. So you can see with the variation here that the fold difference between the highest and lowest protein and fat values can be about 6-fold for fat and about 3-fold for protein. So it's quite a high variation. Next slide. So what does this research mean for our recipients? In this case, as I mentioned earlier, because we pool milk from only individual donors, and we only treat the milk with heat treatment for safety reasons, so we don't change any of the composition. So in this case, it doesn't have any direct impact on the recipients. It's obviously important to provide information to clinicians who use donor milk and make them understand, which they often know that, but to make them understand that the variation can be quite high between batches of donor milk that we supply. And next, so to point out that these values on our nutrition information panel are only averages. Next, please. So the challenge remains that we would like to reduce macronutrient variability for our recipients. And the only way to really do this is to pool or combine milk from multiple donors. And here we used our data from these 200 batches to simulate what it would look like if we combined milk from 3 or 5 donors. And you can see that the spread here has really narrowed down. Next slide, please. Again, what does this mean for our recipients? So if we aim to introduce multiple donor pooling in our processing centers, and this would obviously directly impact our recipients. So we did some more modeling, and you can see in the graph here that we compared single donor pooling, which is shown in green, to different strategies of multiple donor pooling. So you can see the gray that it would be if we mixed equal volumes of milk from each donor. The red, we would mix not exactly the same volumes, but with low variability, and blue is if we if there's quite high variability between the amounts that we use from each donor. And then obviously we modeled it for 3, 4, or 5 donors. So based on this modeling, we found that the best way to reduce variation is to pool milk from 5 donors with equal amounts. And this would directly reduce protein and fat variability for the babies that receive donor milk, and therefore have a direct impact on them. Next slide. And yeah, that's it from us. Thank you. And if you would like some more information, you can visit our website where you can find more information about blood and milk. And I'll pass over to Patrick. Thank you.
Thanks very much, Leonie, and thanks Amanda and Elvina as well. So if we could please have firstly any feedback, you can fill in the form through that QR code, or I will pop a link in the chat now for you. But otherwise, we've got some time for questions. So if you'd like to pop a question either in the chat, or you can use the raise hand function, and I'll invite you to come off mute and ask your question directly. For those who are unfamiliar with Zoom, the raise hand function is hiding under that love heart react in the middle at the bottom of your screen. So if we wait for people to be brave and ask the first question, I will ask the first question. So I've got a question for Amanda. So you were showing differences in return rates based on whether you had a low, normal, or high iron result. And that was over 9 months. And I was thinking to myself, well, the low people are deferred for 6 months. So they've only really had 3 months to return. I was wondering if you've compared return rates in 9 months for those who had a low result, but in only the first 3 months for those who had a normal result. So it's the equivalent amount of time, like opportunity to return. Does that make sense?
Yes, the lows are able to return to donate plasma. So there is an opportunity for them to come back earlier than the 6 months. So that maybe complicates your question here a little bit. And yeah, we will be looking at it long term as well. So we've only had just the 9-month availability, but it's something that we'd like to monitor over time and to kind of see the longer term impacts. Obviously, immediately, yes, they are not as likely to come back, but how does that translate to, say, 12 months or even 24 months? How does that go over 2 years? Yeah, oh, sorry. So I can't really do that comparison.
Yeah. Amanda, I might have a question also for you, Amanda. Do you have difficulties to recruit volunteers, blood donors to respond to your survey, or are they usually all happy to provide answers to your survey?
I think that often depends on the topic and the population that we're asking. So for this particular group, we've had a really good response rate of about 30%. And I think that has to do with the topic. So a lot of donors are interested in iron and to provide feedback on any experience that they've had. And it's also because they've also made a very recent donation. So it's probably still front of mind when we ask them about it.
Do you have any strategies to share, strategies that you use to motivate them being part of the research?
So for this particular one, we've offered them to be part of a prize draw, if that's what you're after. So they had the opportunity to be, they could opt in at the end of the survey if they would like to participate in the prize draw for, I guess, as recognition that they've helped us contribute to that. But that's not always the case. Depends a little bit about what the availability is in terms of funding.
Awesome. So keep your questions coming in if you've got them. Meanwhile, I've thought of one for Leonie. So this was actually a question from my wife when I was chatting to her about milk donation the other day. And she was asking, do we know much about the difference in terms of receiving donor milk or receiving formula for like general immunity of the baby? Like we know the milk provides broad spectrum immunity antibodies, right? Do we know much about any differences there?
You mean for preterm babies?
Yeah, or I mean, even non-preterm, but yeah, I guess specifically preterm in this context.
Yeah, I mean, we know that breast milk has a lot of well, anti-infectious properties and antimicrobial properties. The fact that most milk banks, I should say, heat treat milk means that some of these properties will be reduced, definitely. So this process that we use Holder pasteurization, it will definitely reduce it a little bit. We still know it's better than, or we think we know that it's better than formula. And obviously, there's still some research that needs to be done to see exactly which compounds are antimicrobial. There's often tests we do where it's just the general, like how does milk can inhibit growth of certain bacteria, for example, but that obviously doesn't tell you exactly which components of the milk are responsible for that. So there's still a lot of research that can be done, and that's why we're doing what we're doing.
Excellent. Oh, I'm glad to know you'll be kept busy over the next few years. So I've also got a question for Elvina, and I'm just going to keep asking questions unless anyone else pops one in the chat or is brave enough to raise their hand and ask it. So Elvina, there's a lot of strategies there that we were talking about in terms of future proofing. What do you think is the next cab off the rank, the most likely strategy that we could implement sooner rather than later?
So if you say we, do you mean Lifeblood in Australia or worldwide?
Let's go with Lifeblood. And if you've got a worldwide answer, feel free to share that too.
Because at Lifeblood, we're really we're really proactive. I could see that, you know, a lot of different strategies have been implemented for years already. We've got the environmental and sustainability governance team that is doing a huge work on installing solar panels on buildings, but also we've got different management plans or resilient plans in place. I suppose the most trickiest implementation will be to be able to have more mobile donors, more mobile units in remote areas, but I know this is not easy to implement. So to make sure that we've got enough blood donors of diverse ethnicity. Yeah, and then I suppose my core in my field work, that would be the use of early warning system, but it's still quite hard to develop, and using AI is really promising. So that's what I'm hoping I will be able to focus in the future, personally. We are at the moment analyzing data on floods and bushfires and blood donations to see if there is any patterns obvious at a fine geographical scale. So that's what we're also hoping to finish soon.
Brilliant. Thank you. So we've still got a few minutes. You've
got one question.
Got a question. Excellent.
Yeah.
So Rhiannon asks, I'm wondering if Lifeblood has any future plans to expand the locations for milk donation to more states and territories and even to more rural donor centres. You happy to take that one, Leonie?
Yeah, very good question. Yes, so we are supplying almost all states in Australia now, except for the Northern Territory at the moment. Obviously, most milk donations are limited to metropolitan areas, and this is obviously because, as you can imagine, it's not like blood donations. You go and you spend an hour and you get the required amount. In milk donations, it's that you collect the milk and freeze it for quite a long time until you have the minimum required volume for us to process this milk. And because our donor coordinators go to the donors' homes, we can't really justify driving, 6 hours to collect 3 or 5 liters of milk. So at the moment, we can't collect milk from rural areas. We supply into almost all NICUs in Australia now. So the recipients that are eligible to get donor milk usually now have access to donor milk. And we've just started supplying into Victoria, which is very exciting. It's obviously a big state, so we're very excited about that. But yeah, it's a good question. Thank you.
Yes, thank you, Rhiannon.
Right.
So, you've got a question, Elvina?
No, I want just to add that if anybody wants to contact us, we should have the email on the invitation, so just don't hesitate to contact us. We'll need to close soon now, I think. So.
Yes. On that note, I was going to do a little shameless plug for if you want to hear more about what is happening in Lifeblood research, there is our trending research page where you can read about the latest things that are coming out, including a piece that's just gone up today about the mums behind milk donation. So that's a new one that you can have a read of. Well, if there are no further questions, doesn't look like it. Just remains to thank everyone for coming and thank our wonderful speakers, Elvina, Amanda, and Leonie. They were excellent talks. Thank you very much. And yeah, please pop in your feedback in that survey and we'll see you next time. Thanks very much.
Thanks, everyone.
Thanks,
everyone. Well done.
Bye.
Yeah.